Good afternoon. I hope everybody had a great lunch. And I'm George Rutherford from the University of California, San Francisco, and from the London School of Hygiene and Tropical Medicine. And I'm moderating this afternoon session on vaccines. So first up, we have Dr. Royce Johnson, Royce is the chief of the Division of Infectious Diseases in the Department of Medicine at Kern Medical Center and medical director of the Valley Fever Institute in Bakersfield. Royce. Oh, your foot just got eaten by something. Okay.
Yeah, I think there was a wire on there somewhere. So thank you, you hardy individuals that have lasted this long in the symposium. So my title is Coccidioidal Immunization, Past, Present, and Future. John, not unexpectedly, stole a bit of my talk, and we did have a discussion about that during the break. But without further ado, given that I have lots of stuff. Oh, I do want to take one opportunity. I want to thank the organizers and for planning a wonderful meeting. I think we should give the Academy staff here a round of applause because they've done a wonderful job of helping us with this meeting. And then for Donna Love and maybe other aficionados of Tony Fauci, please note that I'm wearing my official Tony Fauci polka dot tie. So these are my disclosures. The only one of consequence is really the F2G. We've done a little work on olorifim. So where have we been, where are we, and where are we going? That's what I'm trying to do. And the point here being that curing is costly, and that's been demonstrated nicely, and prevention is priceless. So this is the vaccine enterprise over the last, most of it over the last 100 years or so, smallpox going back actually considerably further. This has been a terrific story of success. And if we look at longevity, all kinds of public health measures have improved health more than all of organized medicine put together. Organized medicine probably improves health about 10%, but air, water, food, sewage, fixing poverty, curing tuberculosis, which we can take credit for that, is the other 90%, with immunizations being at perhaps the top of that stack. So in terms of coccidioidal immunizations, it has a lengthy story, really, starting with Rixford, apparently, who is discovered, along with Gilchrist, the first case in the United States at what became Stanford, which was Cooper Medical School, and he inoculated a dog and then produced a lesion and subsequently tried to re-inoculate the dog, and the dog didn't become ill. And then subsequently, we've noted that there are really never secondary infections in even thousands of cases, with the exception of conceivably people that are immunocompromised. And it's very hard to know, frankly. I haven't studied that case, but was that really a reinfection or was it a relapse of a previous infection? So vaccines, we're going to hear more about those. I'm not going to go into the types of vaccines in great detail. Non-viable, epitope-based, nucleic acid-based, and viable attenuated. So the first vaccine, which Dr. Galgiani talked about, really has an ancient history of its own, formaldehyde inactivated arthrochonidia, done by Friedman and Smith in 1956. Levine, along with Papagiannis, were students of Smith, and Levine picked this up and developed the formalin-killed whole spheroidal vaccine that I call Vaccine 1. And this was studied by Levine and Smith, and then subsequently that same vaccine was taken to phase 1 trials with Papagiannis and Paul Williams, who was a Navy officer at Lemoore, and that was published. And before I go further with this, I want to make the point, which I've slightly modified from Santa Ana. Those who forget history are doomed to repeat it when I give you the history of Vaccine 1. So that phase 2 trial, I might have said phase 1, phase 2 trial then led Dr. Einstein, who's the top picture in this slide, to pull together a group of people in Bakersfield saying, we're going to do a vaccine project. I was fairly young at the time, and I was somewhat skeptical that this was going to actually happen. But amazingly enough, Dr. Cunningham, who was a thoracic surgeon, managed to raise somewhere around $1 million. And we did this project for around $1 million. That wouldn't even get you the brochure for a project today. But, and these are the other names here were people from Bakersfield that supported this effort. So the project actually then, Papagiannis at Davis became the PI. Byron Brown did the biostatistics and collected the data at Stanford. We had clinical sites, 3 different ones in the middle of the state run by Paul Williams, who was still in the Navy, and one at Tucson run by John Galgiani, and then the Bakersfield site run by me. And since I am sort of a Bakersfield-centric guy, I'll probably talk more about what we did than what the other guys did. But we did enroll, well, for one thing, we screened a huge number of people, as John described, with 4 different skin tests, 2 coccidioidins and 2 spherulins, meaning different strengths of each one. One was the one, basically the one in a modern skin test, and the other ones were 10 times more concentrated. And so we screened out a bunch of people, but we ended up enrolling, I think it's close to 3, it was like 2,800 people. We screened probably double that number, somewhere approximately. And then he showed you the results. We got low double digits in the placebo, and we got high single digits in the vaccine group. So we definitely did not need Byron Brown to teach us what the p-value for this was. So it did not work. So why did it fail? One, we really don't know what the sensitivity of skin testing is as a marker of prior infection. In fact, there's a fair amount of argument in the recent literature about this. Neil and I did a trial, which I think is the best one, but that's because he and I did it, that showed a very high sensitivity for Serosol, which is basically identical to spherulin, except that its preservative is phenol instead of thimerosal. I figured out during the course of working on this skin test that thimerosal gives you false positive skin tests, and so that's why we had to go back to the FDA and actually why the name Spherosol came about, because it was a changed project because it had phenolic preservation, as does PPD. So in terms of who we enroll, we need to actually know who's had the disease and is immune, and I'll come back to that with my last slide, basically. So we also need a surrogate marker of immune response, because people that were immunized with this vaccine did not necessarily, in fact, most of them did not get a positive skin test. Hilary Levine and I did the sample size calculation, came up with roughly the same number. I think we clearly should have had a different or a larger sample, at least somewhat larger. And also the sample composition was a problem, and I'll show you that in a minute. There's also a problem with the endpoint in terms of infection versus disease and pneumonia. If the animal studies, the mice were not being asked if they had a cough or were short of breath or they didn't have their temperature measured. The vaccine, as John said, was very unpleasant. I've had a lot of vaccines recently. Maybe some of you have too, 5 different COVID vaccines, and I also got a Shingrix or 2 in the last year or so. None of those compare to the whole spheral vaccine in terms of side effect. If somebody was approaching my shoulder, I viewed them as an enemy. So not very tolerable. And there was financial troubles with this study, clearly, too. So I would say that there was a fair amount of community support for doing this vaccine, particularly in Bakersfield. John could speak to Tucson better, but I had 3.5 employees. I had 400 volunteers help me do this, everything from Boy Scouts to physicians. It was a huge amount of work over 6 years. So why did it fail? Dose restriction. The dose of the vaccine was small. 1/1000th of the mouse dose, too small in enrollment, the wrong people. I didn't really let you look at the data, but most of the people in this study were Caucasian. We had very few African Americans, basically no Filipinos, even Latinos, which are a very major part of Kern County population. They did not enroll. And so the archetypical patient or person that we enrolled in this trial was a young, healthy, Caucasian female school teacher. Not the best target population. Again, pneumonia is an endpoint. And if we look at this slide, remember this vaccine is designed for the people in the orange and red. The people in the white and the blue really actually don't need it. So it's a structural problem in terms of infection versus disease. That's a substantial difficulty in recruiting the correct population and having a substantial enough difference to show benefit. At any rate, thank you very much for your attention, and I will return this to George. Wait a minute.
Oh, you got one more? You want to show the last one?
I think
You got 3 more minutes.
I do? Okay. Well, the next part, actually, George should have given the talk, because it has to do with the Valley Fever Vaccine Collaborative and what's happened since. And this was largely sponsored by one of the sponsors of this meeting, the California Healthcare Foundation, and it was 5 sites to develop more vaccines. And one of these was the TK, or the T27K from Davis. There's a myriad of other ones. There's papers on this written by Theo Kirkland historically, and there is also, I would turn your attention to 3 papers, and if I leave your paper out and you're annoyed with me, you can tell me at the break. There's a paper by Rebecca Cox and Mitch McGee in 2004 that summarizes some of this early work. There's a very much more recent paper by Josh Fear, who's here, and Theo Kirkland that summarizes the work that's more recent. And there's also this slide that from Morgan Goris, who's here today, that also shows many of the antigens that were developed as part of this flowering of episodes or of attempts to produce antigen. Most of these only stayed in mice, and there hasn't been any ability to bring any of these antigens forward as vaccine candidates into humans. That doesn't mean that it couldn't be relevant research to that project, however. Coccidioidal immunization, dose response, and this is sort of a dig at John Rex, that you can't get a PRO in a mouse. Intraperitoneal versus intranasal dosing of the arthroconidia, a pneumonic disease in successful immunizations, meaning mice did have evidence of pneumonia, even though they were called a success in terms of being immunized. And then the immune status of the animal. Different mice and different dogs clearly have different susceptibility. So there's lots of complexity to this animal data. So considerations for future phase 3 trials are sample size, measurement of prior immunity, and sample recruitment and retention, which I think would be harder now than it was in the 1980s. Success is not final, failure is not fatal. It is the courage to continue that counts. Winston Churchill, one of my favorite people. So again, so for a second time, thank you for your attention.
Thank you very much, Royce.